AVF. The next 6 leads represent the horizontal plane of the heart. They are called precordial leads and are named V1, V2, V3, V4, V5, and V6. The arrangement of the leads produces the following anatomic relationships. Leads 2, 3, and AVF represent the inferior surface of the heart. Leads 1, AVL, as well as V5 and V6 represent the lateral wall of the heart. Leads V1 and V2, the septal portion, and finally V3 and V4 representing the anterior portion of the heart. There are 6 leads and are produced based on what we call the Einthoven's triangle to capture the electrical impulses along a person's coronal plane. These 6 limb leads are produced by attaching the electrodes to the person's arms and feet, producing leads 1, 2, 3, AVF, AVR, and AVL. We have 6 chest leads. V1 on the 4th ICS right parasternal border. V2 on the 4th ICS left parasternal border. V3 between V2 and V4. V4 at the 5th ICS left midclavicular line. V5 at the 5th ICS left anterior axillary line. And finally, V6 at the 5th ICS left mid-axillary line. Vectorial analysis basically provides the guidance as to the direction of impulse generation. If the impulse moves away from the lead, then it will produce a negative vector on your tracing. If the impulse moves towards the lead, then it will produce an upright or a positive vector on your tracing. And since we are discussing waveforms, we must emphasize that one of the very first steps to ECG interpretation is standardization. You look for the standardization tower, which should be roughly 10 millimeters in height. It tells us if the waveform is printed with its true amplitude or if it is half standard and underestimated. Each big box is comprised of 25 small boxes in a 5 by 5 manner. The vertical axis represents voltages with one small box, representing 1 millivolt. And the horizontal axis denotes time, with one small box as 0.04 seconds. Hence, one big box is equivalent to 0.2 seconds. The normal ECG waveform is comprised of several waves or deflections, as can be seen in this picture. We will be discussing each component in detail. There are segments and intervals in your ECG. These segments represent horizontally directed lines representing numeric distance. Meanwhile, intervals represent the time frame in seconds that elapses as the distance between two reference points on the ECG tracing. Now let's look more closely at the components. The first waveform that we can discuss is the P wave. One of the most important aspects of the ECG tracing is to check for normality of the P wave, which might be the first clue to the presence of sinus rhythm. The P wave represents atrial depolarization and begins at the sinus node, particularly at the high right atrium, moving leftward to the left atrium, and finally inferiorly towards the AV node. It should inscribe a positive deflection in lead 1, 2, and AVL and AVF, and negative in AVR, upright and biphasic in lead V1. Normally, the duration should be less than 120 milliseconds. After the P wave, we need to look at the PR interval. As mentioned earlier, this represents a time frame, and it also represents slow conduction within the atrioventricular node, which definitely allows for ventricular filling. This is best determined from lead with the shortest PR interval, and normally it should not be more than 200 milliseconds. One of the most prominent aspects of your tracing is the QRS complex, and this represents left ventricular depolarization. Each P wave should normally be followed by a QRS complex. Note also that R wave amplitudes should normally increase in amplitude as it progresses from V1 to V6. This is called the normal QRS progression. Next, we looked at the QT interval. This is the measurement from the Q wave until the end of the T wave, and many arrhythmias can arise from abnormalities in the QT interval. It is best determined in the lead with the longest measurement. Usually that's V2 and V3, and it should not have a U wave. When you get your QT interval, normally it should be corrected. And the traditional go-to formula is called the Bazet's formula, shown in the following slide. You can plug in the numbers to get the corrected QT to help you determine whether this patient's QT interval is normal or not. The STT waves represent the early repolarization of the ventricles. Its polarity is usually the same as the net polarity of the preceding QRS complex and is usually positive in leads 1, 2, AVL, AVF, and negative in AVR, and it might be variable in the following leads, 3, V1, and V2. Any STS segment elevation or depression or T-wave inversion can be indicative of ischemia or infarction. Note that changes in your ST and T waves should be compared to a reference isoelectric point that is traditionally the TP segment. The U wave, which is not always present, is a low amplitude wave following the T wave. It represents late repolarization, and it is usually largest in leads V1 and V2 and is more prominent in slower heart rates. After knowing the components of a normal ECG wave, let us now develop a logical approach to interpret the standard 12-lead ECG. Let's start. Follow these steps in the systematic review of your ECG. First, determine the heart rate, check the rhythm, determine the axis, measure important intervals, check for chamber enlargements, check for signs of ischemia or infarction, finally look for other miscellaneous findings. For rate, there are a lot of ways to compute the heart rate. You can use the toxic formula method, which is 1,500 divided by the number of small squares between two RR intervals. You can use an alternative formula, or actually you can use eyeballing as follows. If the RR intervals are separated by one big box, the estimated heart rate is roughly 300. Two big boxes is 150. Three big boxes is 100 beats per minute. Four big boxes is 75 beats per minute. And finally, five big boxes will translate to 60 beats per minute. How about for irregular rhythms such as AF? Well, we need to get a 6-second strip. Usually that's long lead 2. And count the number of QRS complexes. Multiply by 10 to get the rate in 1 minute. For rhythm, heart rhythm is basically determined by the SA node. What should you see? P waves that are consistent, normally upright in the leads that I mentioned earlier, 2, AVL, AVF, and every QRS complex should be preceded by a P wave, and this is called atrioventricular association. And finally, the RR intervals should be equal. Next, we talk about axis. The frontal axis basically gives us an estimation of the general direction of the cardiac impulse. Leads 1 and AVF would probably be the most important leads to check when assessing the patient's frontal axis. These are the cutoffs for normality in axis. Patients can be either in normal, left, right or extreme right axis. The first method is what we call the thumb method. Using your left and your right thumbs, you assign them to leads 1 and AVF. If both thumbs are upright, meaning both inscriptions on leads 1 and AVF are generally positive, you can safely say that the axis is normal, within the range of -30 to 100. You can use the following guides as well. If the left thumb is upright and the right is down, then that is generally a left axis. The converse will hold true. If the right thumb is upright and the left is not, then you can predict that this patient has right axis deviation. And if both thumbs are down, then generally you would suspect that there might be an extreme right axis or indeterminate axis. This is the summary of the thumb method. Only estimates. To get a better determination of axis, we use what we call the hexaxial method. Using the 6-axis, we look for the most isoelectric limb lead. So looking at limb leads 1, 2, 3, AVR, AVL, and AVF, we would zero down on AVL as having the most isoelectric or isophasic pattern. Because of AVL, there are only 2 options for axis. And using the thumb method, you can now verify that this patient roughly has an axis that is normal. An estimate would be positive 60 degrees in your interpretation. Now, let's look at the normal ECG. Is the ECG normal? These are the questions to ask yourself. Is the rate within the normal range, 60 to 100? Is the rhythm regular? And is it generally sinus? Is the axis normal within the range of -30 to 90? Is there any evidence of chamber enlargement? Are there changes in your STT waves that might suggest ischemia or infarction? Are the following intervals normal, the PR, QRS, and the QT intervals? If the answer is yes to all, then you can safely say that you have a normal 12-lead electrocardiogram. Let's have some exercises. Take a look at this ECG tracing and tell me what you think. Is this a normal ECG tracing? Let's go through the steps. The rate is basically normal, as you will see that our intervals are fit within 5 big boxes just by eyeballing. To be more precise, the rate of this patient is roughly 70 beats per minute. And you will see P waves that are normal looking, upright in leads 2, 3 AVF, 1 in AVL, negative in AVR, with normal intervals, and a QRS complex that is narrow following each P wave. Note also that the following intervals are also normal. And finally, the axis is roughly normal, computed at 53 degrees, but you can say that it is probably in the range of 60 degrees. How about this tracing? Is this normal? Again, let's look at the rate. Still encompasses 5 big boxes, so we would predict that the rate will probably be in the range of 60 beats per minute. Are there P waves here? Yes, you can see P waves. And are they normal in appearance? PR interval is normal. The QRS is narrow. The QT interval is narrow and normal. And the axis, however, is in the negative category. Let's take a look. Lead 1 is your left thumb, it's upright, and AVF is your right thumb, which is downward, which means this should be in the left axis deviation category. Finally, is this ECG normal? Again, look at the rate, look at the rhythm, the P waves, are they normal? Is it followed by the QRS all the time? Is the QRS narrow? And are the intervals narrow? Is there any change in the STT waves? Is there evidence of chamber enlargement? And is the axis normal? How about this tracing? Just by eyeballing, you will see that this is running at a fast rate, probably more than 100 beats per minute. You would need a 6-second strip because it is irregular. And one quick differential for an irregular and fast rhythm is, of course, atrial fibrillation. One clue is the bizarre-looking baseline and undiscernible P waves here. So to recap, hopefully by now you know how to correlate the cardiac action potential to the ECG, recognize the components of the normal tracing, and formulate a logical approach to 12-lead ECG interpretation. Congratulations and enjoy your ECG reading.
Welcome to our session for the clinical applications of L-carnitine for cardiovascular conditions. I am Dr. Richard Yonko. I'll be your moderator today. We'll be examining the available evidences of efficacy for L-carnitine for cardiovascular application. And what better way to do this than by inviting and listening to one of our esteemed professors at the Division of Cardiology in the UP College of Medicine, Dr. Roddy C. Dr. Roddy C. is Professor, Department of Medicine, UP College of Medicine, Head for Research Generation, UP College of Medicine since 2012, Member at Large, Executive Committee, International Atherosclerosis Society since 2012, President, UP Medical Alumni Foundation since 2014, 2019 Top 100 Scientists for Biomedical Science, Asia Scientist Magazine, and last but not the least, academician, National Academy of Science and Technology just from last year. Our dear Professor Dr. Roddy C. hopes to enlighten us more than just the value of what we think might be L-carnitine for metabolism, this time for cardiovascular purposes. And hopefully at the end of the day, we learn more about this preparation of L-carnitine. Ladies and gentlemen, let's welcome Dr. Roddy C.
Hello, good afternoon, everyone. Thank you, Ricky, for your kind introduction. For this afternoon, I have been requested to talk to you about the clinical applications of L-carnitine for cardiovascular conditions, showing you the available evidences of efficacy. These are my disclosures for my lecture today. And I'd like to start off with the treatment of congestive heart failure. As we know, congestive heart failure can be treated with the reduction of preload and afterload, and also with the introduction of inotropics. There are a lot of data already on this. I'd like to discuss with you today about energizers that may help improve heart failure or cardiac metabolism. Of these energizers, we know of three entities or three substances. These are coenzyme Q10, trimetazidine, and L-carnitine. This may improve microcirculation, may improve metabolism in the cardiac muscle. I'd like to share with you the cellular actions of L-carnitine. This is a review article published in 2014 showing us the effect of L-carnitine. L-carnitine is a naturally occurring substance that is produced in our body, in the liver and in the kidneys. It works by carrying the long-chain fatty acid from the cytosol to the mitochondria, because accumulation of long-chain fatty acid in ischemic myocardium can be detrimental. So with the movement or transport of the long-chain fatty acid from the cytosol to the mitochondria, it can improve the beta oxidation, and with this, it can produce more ATP. With that, there will be more energy for cardiac contraction. The L-carnitine has also been shown to have antioxidant property. It acts as a scavenger of free radicals, hydrogen peroxide, and superoxide anion. With this, it will reduce the metabolic stress in cells, specifically in the myocardium. It can also increase the levels of PPARs, or the peroxisome proliferator activated receptors. As we know, PPARs are involved in lipid metabolism. So with this action, L-carnitine can improve the lipid profile or cholesterol, HDL levels in patients receiving this substance. I'd like to continue by showing you the evidences for the efficacy of L-carnitine in a chronologic order. So the first paper that I will discuss is this one published in 1983 by Kobayashi on animal studies. He did this on 35 anesthetized dogs, and he ligated the LAD for 40 minutes and then reperfused for 15 minutes. The ATP in the L-carnitine group was significantly higher. Accumulation of long-chain acyl-CoA was reduced by the L-carnitine group. L-carnitine can significantly reduce incidence of ventricular fibrillation after reperfusion. So with this, his conclusion in this paper is that L-carnitine has protective effects on ventricular arrhythmias and on metabolic changes after coronary artery reperfusion following coronary artery occlusion. The next paper that is considered important is probably following that animal study. This is the one published by Rizon in 1989 in the European Heart Journal. He looked at in 56 patients with an acute myocardial infarction within 3 to 12 hours. He gave intravenous L-carnitine every 12 hours for 4 doses and did Holter monitoring for the first 48 hours of his study. His purpose is to investigate whether administrations of high-dose L-carnitine in myocardial infarction could reduce fatty acid accumulation due to decreased rate of beta oxidation believed to be the cause of ventricular arrhythmias. And his findings showed that the patients on L-carnitine had significantly less ventricular ectopic activities on day 2 of his Holter monitoring. The next paper is the one by Eliseto, done in Italy and in Netherlands. No? This is the effects of L-carnitine administration on left ventricular remodeling after an acute anterior myocardial infarction. This is the SEDIM trial. No? And he followed these patients with echocardiography. He randomized, this is a randomized double-blind placebo-controlled study with a total of 472 patients recruited. These patients have their first acute myocardial infarction with 239 in the placebo group and 233 in the L-carnitine group. As I said, this is an echocardiographic study, and with this, he was able to show at 3 months, 6 months, and 12 months progressive or persistent reduction in the end diastolic volume and end systolic volume, with the stroke volume being maintained. So the conclusion of this study is that L-carnitine treatment initiated early after acute myocardial infarction and continued for 12 months can attenuate left ventricular dilation during the first year after acute myocardial infarction, resulting in smaller left ventricular volumes at 3, 6, and 12 months after the emergent event. The next study is a local study, not published by Dr. Jacoba, of course, with the supervision of our well-known Dr. Abarquez. This is the effect of L-carnitine on the limitation of infarct size in 1 month post-myocardial infarction cases. He followed up these patients with nuclear study. And his conclusion showed that at rest, L-carnitine gives greater improvement in myocardial viability in the areas of the left anterior descending artery and right coronary distributions. This reinforces the fact that the myocardium in an infarct zone can also be in a state of hibernation or stunning, which in other words is capable of improving. The next article that I'd like to share with you is the meta-analysis published by D. Nicolantonio, and this is a systematic review and meta-analysis of L-carnitine in the secondary prevention of cardiovascular disease. So the first entity that he looked at, but before that, I'd like to say that this particular meta-analysis involved 13 studies with a total of more than 1,600 subjects. I think, I'm sorry, I think 3,600 patients. No? And unfortunately, not all of the 13 studies will have all these parameters measured. This particular parameter on all-cause mortality involved 11 studies that reported on this. And it showed a significant reduction by 27% now on all-cause mortality. The next item is post-angina occurrence. Unfortunately, there were only two studies that reported on this. With these two studies, there was a 40% reduction in the occurrence of angina after myocardial infarction. And the next entity is with regards to ventricular arrhythmias. There are 5 studies that reported on this, and there was a very significant reduction by 65% on the incidence of ventricular arrhythmias in those treated with L-carnitine. Therefore, this particular meta-analysis showed that L-carnitine is associated with 27% reduction in all-cause mortality, a 65% reduction in ventricular arrhythmias, and 40% reduction in anginal symptoms in patients with acute myocardial infarction. The next study that I will share with you is another meta-analysis published in 2017 by Song. This is to look at chronic heart failure. His report is entitled Efficacy and Safety of L-carnitine Treatment for Chronic Heart Failure. He included a total of 17 studies with more than 1,600 subjects. So first entity that he looked at is all-cause mortality. In his study, with only 4 publications reporting on this, he was not able to get a significant reduction in all-cause mortality, although the graph on the right side will show you a tendency to improvement with L-carnitine. The next entity that he looked at is BNP measurement. As we know, BNP is a measurement of heart failure status. And this particular entity looked into by 3 studies showed a significant reduction in BNP level in the L-carnitine group. A more specific measurement is the NT-proBNP. And again, the reduction is favoring the use of L-carnitine. With left ventricular ejection fraction measurement, there were more studies in this, and it showed a reduction, a mean reduction from this meta-analysis of 4%, favoring the use of L-carnitine. Because of this, his conclusion in this meta-analysis is that L-carnitine treatment in congestive heart failure patients may improve clinical symptoms and cardiac function and decrease serum levels of BNP and NT-proBNP. With all these studies, we can conclude of the following, that number 1, L-carnitine as an oxidant is an oxidant, and its ability to increase ATP production may benefit patients with heart failure and ischemic heart disease. Number 2, L-carnitine may increase the occurrence of ventricular arrhythmias in post-MI patients. And number 3, L-carnitine treatment in congestive heart failure patients may improve clinical symptoms and cardiac function, may decrease serum levels of BNP and NT-proBNP, and reduction of all-cause mortality in at least 1 meta-analysis. So thank you for your attention.
Okay, so good afternoon, everybody, and I hope you enjoyed that review by our esteemed mentor, Dr. Roddy C. It's time now for around 6 minutes plus of Q&A. So it's our opportunity now to get to reach out to Dr. Roddy C. and ask him some questions. And I do believe there are some that are already lined up, Dr. Roddy. May I give you the first one? There's one question here that says, can we give L-carnitine to patients with acute decompensated heart failure?
At this point, with the data that I've shown, it may benefit patients with heart failure because in the meta-analysis that was published in 2017, it showed that it can reduce left ventricular dimensions, specifically end diastolic volume and the end systolic uh, diameter. That will translate to uh, reduce end diastolic and end systolic volume as well. No? So in that regard, and then with the reported reduction in ejection fraction, those are all consistent, no, towards improving heart failure.
Yes, that's a interesting note, Dr. Roddy, and it would be exciting to find out how it will do in a clinical trial, no, up to date
Yeah.
right now. And the next question is, Dr. Roddy, can this be given to pregnant or lactating women?
Uh, I'm not too sure about that, no, to be honest, because we do not have data, no, to show whether this will be safe in patients to look into the data in this regard. No, I cannot answer that question at this point.
Mm-hmm. Perhaps if we look at the similar molecules or preparations for L-carnitine, the other data shows that it might be pregnancy B, but Dr. Roddy is telling us that we have to further look into the validity of these recommendations for this regard. But otherwise, generally, carnitine appears to be class B. Okay, the next question, Dr. Roddy, is there
Okay.
benefit of L-carnitine in high-risk patients but have no heart disease? Interesting.
Uh, this is being given for patients with heart disease. So without heart disease, it may be difficult to justify it in that regard. But there are data showing that it may improve patients with kidney problems or chronic kidney failure or chronic kidney disease. So in that regard, it may be helpful.
Yes, actually, Dr. Roddy, I saw that in Up to Date, they had a peer review for uremic myopathy and improving muscle strength for that regard and fat metabolism. So all these discussions that we're having on cardiovascular effects of L-carnitine are really peculiar and fascinating. The next
Yes.
question is there a maximum dose for L-carnitine?
From the meta-analysis, no, it grouped so many studies with various dosages employed. It varies from just 1 gram up to 6 grams, no, given per day. And the usual recommendation is to give it at around 1 to 2 grams a day.
Okay, so I think there are more than 4 people who asked the question of the dosing. So that's what Dr. Roddy has reviewed for us today. Right.
Yeah, and then maybe I can add that the preparation, the newest preparation by McGraw is a 500 milligram soft gel. So this can be given twice a day, at 1 soft gel twice a day or 2 soft gels twice a day.
Yes, I was going to ask you about that, Dr. Roddy, because I'm sure there are a lot of people out there who are asking if it's a feasible option in the Philippines, because they probably see it on the shelves of supplements or other stores. But I do believe that the one that you're saying is available in the drugstores, right, Dr.
That's
Roddy?
correct. That's correct. And it's at a higher concentration because
Mm.
the other preparations have lower concentrations.
Mm. Okay, there seems to be a question with regards to safety or adverse events. What were the common adverse events, if any, that you have encountered in your reviews, Dr. Roddy, or in your practice for L-carnitine?
It has been reported that this is a very well tolerated preparation, no? Because this is something that is present in our body and or generated by some organs in the body. So generally well tolerated, if at all, usually gastrointestinal, no, in some patients, but very minimal.
Hmm. Okay, there's an interesting question here. It's a little off the map from cardiovascular. They listen to us in terms of, you mentioned in dialysis patients and patients with cardiovascular disease all the way back from the 90s, and now meta-analysis have actually revalidated and revisited, and you have this demonstrated actually the effects on mortality benefit, arrhythmia, and angina. This doctor is actually interested if perhaps he asked this question for autism spectrum disorder. Dr. Roddy, have you encountered any literature on this treatment effect for L-carnitine?
Uh, I'm not sure, no, because I think I came across it, but I did not pay attention to that aspect. So I did not expect that to be brought up today. So I have to review to go back to the literature. I don't know if you have any information on that.
Okay, Dr. Roddy C, pardon me for asking another sideline question because the interest here actually is cropping up faster than I can read. No, can we give L-carnitine to cancer patients and post-op patients? I think they're probably thinking of disease modulation or inflammation changes for L-carnitine. Is there any data on this?
I think there are isolated reports in cancer patients, no, and supposedly it can improve the nutritional aspect, and it may improve appetite as well. So these are beneficial effects that may be obtained. And because L-carnitine can improve metabolism or production of energy, so it helps cancer patients to feel better.
Interesting. Okay, I think Dr. Roddy, this brings us to our last question. Is there any contraindication for L-carnitine?
Uh, I cannot think of any. No? In clinical practice, as I said earlier, this is very well tolerated, and if patients may have side effects, but in terms of contraindication, I cannot recall of any.
Yeah. Thank you, Dr. Roddy C, for all your generous time in helping us understand about this preparation for L-carnitine. And that brings us to a close, ladies and gentlemen, for our session on this review on L-carnitine, what is locally available as the 500 milligram Lipicap, no? That is available as a prescription or through the drugstore, that is, as Dr. Roddy has said. Thank you for joining us and good afternoon.
Thank you, Ricky.
Bye, sir.
Bye.
To discuss the topic entitled That Doesn't Look Right, Overview of Abnormal ECG, let us all welcome Dr. Felix Eduardo Punsalan.
Hello. After learning the basics of normal ECG, this session will give an overview of the abnormal ECGs. It is when the ECG doesn't look right. Our goal is to have a practical approach to recognition of common ECG abnormalities and give some pointers on what to look for, where to look at, and how to recognize them. We will not discuss all the criteria, but will highlight some of their features that are helpful in identification. The main reference for this presentation is our ECG book, My First ECG Handbook. Furthermore, we won't cover all abnormalities, the combination of specific abnormalities, nor discuss the electrophysiologic mechanisms or etiologies. They will be tackled by the focus lectures on the specific topics. We will follow this approach starting with the rate, since it's easier to notice, the rhythm, then identify conduction problems, chamber abnormalities, then ischemia and infarction, focusing on the ECG waves, segments, and complex, examining morphology, duration, and their relationships. Remembering the normal ECG complex and what it represents help a lot in recognizing the abnormalities. Remembering how a normal ECG looks like is very helpful. The rate is not fast or slow. There's constant PP and RR interval pointing to regular rhythm. P is upright at lead 2 and also in 1 and ABF, where our waves are also upright, indicating normal axis. There is no aberration on PQRST morphology, interval, and relationships. ST is not deviated from isoelectric baseline, and there's good R-wave progression in the chest leads. If the ECG doesn't look like this, then we have to closely scrutinize the tracing. We have learned from the normal ECG lecture how to calculate the rate. Is it useful to look at long lead 2? The normal rate is 60 to 100 complexes per minute. If it is less than 60, it's bradycardic, while it's tachycardic if it's more than 100. Some publications advocated a rate of less than 50, as most patients only become symptomatic when the rate drops to that level. This is how an ECG with slow rate looks like. These different tracings at long lead 2 show sinus bradycardia, junctional, and idioventricular rhythm. How do we differentiate now? The first step is to check if there is a P wave preceding every QRS and assess if they look the same and upright in lead 2. If the answer is yes, consider sinus bradycardia. A sinus or normal P has a smooth contour and upright in lead 2. When there is severe sinus bradycardia, an escape rhythm may take over. It could come from the AV node or ventricle. Now, if there is no discernible P wave before QRS, check the QRS interval of the complexes that appear regularly. If it's normal, think of junctional rhythm. With this rhythm, P wave may not be obvious since it's absent or buried in the QRS or retrogradely conducted and inverted at lead 2. Now, if there's no obvious P and the QRS is wide, consider idioventricular rhythm. Remember that junctional and ventricular rates are naturally lower than 60. Ideally, all leads need to be examined for P waves as they may not be obvious in some leads. This slide shows the distinguishing features of the previously presented ECGs. Let's proceed with fast rate. This is how an ECG of a patient with tachycardia may look like. These strips from long lead 2 show tracings with fast rate. To have an idea about the tachycardia, we will have the similar approach. Is there P wave preceding every QRS? Do they look the same and upright in lead 2? If yes, then consider sinus tachycardia. On the other hand, supraventricular tachycardia is considered if there is no obvious or discernible P wave. It may be buried in the QRS, and the QRS interval is generally narrow. If the QRS is wide or bizarre in appearance, then think of ventricular tachycardia. Wide QRS can also be due to aberrant conduction, which is beyond the scope of this session, and it will be covered by focused lecture on wide QRS arrhythmia. This slide shows the features of the ECG strips, the basic approach to estimate the rate, then look for two things: P preceding QRS and QRS duration. Let's go to rhythm abnormalities. This is a normal ECG with a regular rhythm. Variability in RR interval prompts us to check for irregular rhythm. Again, long lead 2 is helpful for this. We will tackle those with early beats and those with generally irregular rhythms. Irregularity may happen due to early or premature beats. It presents as a complex occurring earlier than the next anticipated sinus beat. We can appreciate the premature beats by again looking for P as well as QRS morphology in the premature complex. If there is P in the early beat, then it is a premature atrial complex with impulse coming from another region of the atria. The P morphology is different from the regular sinus P. Again, if there is no discernible or obvious P, it could be buried or retrogradely conducted. And if the QRS is narrow, then think of premature junctional complex. If the P wave is absent and QRS is wide, then consider a premature ventricular complex. This is the summary of the features of the premature beats. Generally, irregular rhythms at times are more intimidating than premature beats. Just remember to approach it by looking for P waves and QRS complex. Let's try to understand these strips from long lead 2. Check the P waves at long lead 2. If there are identical upright P waves before its QRS complex with varying RR interval, then consider sinus arrhythmia. If the P waves are not identical, with 3 or more morphologies and the heart rate is normal, then think of wandering pacemaker. But if the heart rate is more than 100 beats per minute, then consider multifocal atrial tachycardia. This is the summary of the features of the different irregular rhythms. Another common abnormality appears with irregular rhythm. If we cannot find any P wave and just low amplitude baseline oscillations, then we consider atrial fibrillation. Combining the concept of rhythm and rate, in atrial fibrillation, if the rate is normal, it is referred as controlled ventricular response. Rapid ventricular response means the rate is fast, and if it's slow, it is called slow ventricular response. Another condition can present with absent P wave, but with identical, regular, very frequent sawtooth waves best observed in leads 2, 3, ABF, and B1. In contrast to atrial fibrillation, the rhythm is usually regular, though sometimes it could be variable. It is called atrial flutter. In relation to irregular rhythm, a group of abnormality can present with dropped beats due to problems of atrioventricular conduction. We had appreciated the value of checking P and QRS morphology on previous ECGs. Now we'll focus on PR interval. AB block occurs when impulse conduction from the atria to ventricle is impaired. The strips show obvious pause after a P wave, which is what is referred to as drop beat. To check for AB conduction abnormalities, we measure PR interval. If it is prolonged with constant interval and no drop beat, it is first degree AB block. This one does not lead to irregular rhythm. If there's gradual prolongation of the PR interval followed by a drop beat or non-conducted P, presenting with a pause, then it is second degree AB block Movitz type 1. For the third strip, the PR interval is constant, but with sudden non-conducted P. Then it is referred to as second degree AB block Movitz type 2, wherein progressive increase in interval is absent. The last ECG is the most severe form of AB block, with P waves being completely unrelated to the QRS complexes. It is called third degree AB block. Second degree AB block can be perceived as irregular rhythm due to group beating, while third degree AB block presents with bradycardia having junctional or ventricular as the escape rhythm. As a recap, we have already discussed rate, rhythm, and AB conduction abnormalities, which are readily noticeable at long lead 2 with the help of examining P, PR, and QRS. As PR interval gives us a clue to AV conduction issues, QRS morphology can also point to blockade of conduction through the bundle branches. For this, examining the chest lead is helpful in recognizing bundle branch block. For left bundle branch block, one obvious manifestation of delayed left ventricular activation is the broad, notch, or slurred R waves in B5 and B6. Complete LVBB is considered if QRS duration is prolonged. For right bundle branch block, look at RSR pattern at B1 and B2, more commonly known as bunny ears. As you have noticed, there are also concomitant reciprocal changes in the contralateral leads in bundle branch block. Now we can also use the chest leads and the concept of association of B5 and B6 with the left side of the heart and B1 and B2 with the right side of the heart as we proceed with ventricular hypertrophies. Measuring the RNS amplitudes can identify hypertrophy. Estimating the axis, as you have learned in the lecture of normal ECG, also helps. For left ventricular hypertrophy, we will see taller R in left-sided leads, specifically B5 and B6. Applying the commonly used criteria, when the sum of R in B5 and S in B1 is more than 3.5 millivolts, then it is read as left ventricular hypertrophy. There may be a concomitant left axis deviation signified by upright lead 1 and negative ABF. For right ventricular hypertrophy, the chest leads nearer the right side shows which B1 exhibits taller R amplitude, with B5 and B6 having deep S. There is also right axis deviation manifested as upright ABF and negative lead 1. Now, for the atrial chambers, P-wave morphology can help identify atrial abnormalities. Useful leads are lead 2 and B1. For left atrial abnormality, P-wave duration is prolonged, notch in lead 2 and biphasic in B1 with terminal component more than 0.04 seconds. For right atrial abnormality, we can see tall upright P-wave more than 2.5 millimeter at lead 2. So for left atrial abnormality, look for notch prolonged P-wave, while for right atrial abnormality, check for increased amplitude. Since we usually scan lead 2 first, we can analyze the P-wave right away, then looking at B1 can further help. So far, we have underscored the value of looking at P-waves, PR interval, and PRS complex. Now let's proceed to ST segment and Q-wave as we assess ischemia and infarction. For these abnormalities, we should systematically scan the whole ECG for their presence at a specific location or wall. Leads 1 and ABL pertains to high lateral wall. 2, 3, and ABF points to the inferior walls. B1 to B4 refer to the anterior wall. If it's only B1 and B2, it points to septal involvement. And lastly, B5 and B6 pertains to the lateral wall. There is also right ventricular infarct, and it can be seen in right-sided 12-lead ECG. It will be further discussed in the focused lecture on infarction. We should look for ST deviation from the isoelectric baseline. Consider ischemia if there is ST depression or T-wave inversion based on these features. Downsloping or horizontal ST depression are more specific. If we see ST elevation, then consider acute infarction. Identifying the presence of ischemia or infarct is the first part. We must also localize it. So remember the localizations mentioned. So we ask, is there ST deviation? Is it ischemia or infarct? Then localize. This ECG shows a significant ST depression at B5 and B6. So there is ischemia that we need to specify the location. Using the specific leads to localize, B5 and B6 point to lateral wall, so we read it as lateral wall ischemia. For this next ECG, we look for ST deviation. It shows ST elevation at B2, 3, 4, 5, and 6. So there is infarction. Now let's localize. Using the specific lead to localize, these leads point to anterolateral wall. So we read it as anterolateral wall myocardial infarction. The previous ECG also showed Q waves on the leads mentioned. At this point, let's discuss pathologic Q waves. Q wave is considered abnormal based on these features. It may or may not be present in acute myocardial infarction. If it is not associated with ST elevation, then we refer to the infarction as old. We have gone through recognizing the more common ECG abnormalities up to ischemia and infarction. As a reminder, presence of STT deviation does not always mean there is infarct or ischemia. It is important to remember the criteria. If the STT alterations do not fulfill them, the term non-specific STT wave changes is usually applied. This brings us to the last part by looking at some common miscellaneous findings. Now we will emphasize the importance of checking QT interval and T wave. We have chosen 4 commonly encountered ECG changes due to electrolyte abnormalities. Hyperkalemia is associated with repolarization abnormalities. Its early sign is diffuse peak T waves based on the definitions given. An important caveat here is that if peak T waves are only found on a specific location, as in infarction, we must suspect an evolving MI. Serial ECG monitoring is needed. Meanwhile, for hypokalemia, ECG shows flattening of the T waves and prominent U waves best seen in the precordial leads. Let's proceed with calcium abnormality, which are more related to QT interval. Hypercalcemia causes QT prolongation. Look for lead with the longest QT interval, usually V2 or V3, and without a U wave. This sample ECG showed QT computed of 530 milliseconds. Remember the lecture on normal ECG for the computation. On the other hand, hypercalcemia presents with shortening of the QT interval. This ECG sample showed marked shortening of the QT interval of 260 milliseconds. In summary, we presented in a systematic way the more common abnormalities, what to look for, and where to initially look for the particular concern as shown in this slide, and emphasize the importance of analyzing PQRST ideally in every leads in terms of morphology, intervals, isoelectricity, and relationship to each other. Remember that abnormalities can present in complex manner like fast rate with irregular rhythm or slow rate with infarct, but systematic approach helps in their recognition. These abnormalities will be discussed in detail in the succeeding lectures, and your questions will be answered during those sessions as well. To be more proficient, it will be taking a bit of effort requiring understanding of basic mechanisms and some memorization and pattern recognition. But I guarantee you it will be worthwhile. Practice reading ECGs. The more you see, the more you will remember. Sometimes it's easy, sometimes it's not, but that's fine. Just like an ECG, it's better to have ups and downs than none. I'm sure you understand why. So let's keep on reading ECGs, have fun. Thank you for your kind attention. Be safe.
The views and opinions that are expressed by myself and Dr. Steele are, of course, our own and don't necessarily represent or reflect those of Pfizer or any of its affiliates. Of course, the intent here is to provide continuing medical education and an opportunity for a dialogue. We will leave all sort of clinical decisions, of course, in the future to these types of patients to you. Of course, one should always refer to the package insert of any product, including the anticoagulant therapy that we're going to be talking about for full prescribing guidelines. And if there's any suspected side effects or adverse reactions, please, of course, contact your local Pfizer country office to report those. So here's the case, a 69-year-old woman with new onset atrial fibrillation that was detected on routine examination. She's actually asymptomatic from an atrial fibrillation perspective. Her past medical history is remarkable for hypertension, for hyperlipidemia, and she experienced a non-ST segment elevation myocardial infarction approximately 5 years ago, which was managed with a stent in the proximal right coronary artery. She has relatively preserved left ventricular systolic function and is coming currently on the following medications: aspirin, ramipril, amlodipine, and atorvastatin, with the doses noted on the slide. Her physical examination, relatively unremarkable. I will point out that her ventricular response rate is not particularly elevated. It's 87 beats per minute. Her pulse, of course, is irregular, and her ECG confirms that she's in atrial fibrillation, which she was not known to be previously. She also has some voltage criteria consistent with left ventricular hypertrophy. And importantly, her laboratory investigations are generally unremarkable, except for the fact that her creatinine is 1.7 milligrams per deciliter, corresponding to a creatinine clearance of just about 37 milliliters per minute and an estimated GFR of 30 milliliters per minute. what would be your antithrombotic strategy, given that this patient with established chronic stable coronary disease now presents with atrial fibrillation? She's not symptomatic from it. So would you keep the patient on the aspirin that she's currently on for her underlying coronary disease as secondary prevention? Would you continue aspirin and add another antiplatelet therapy like clopidogrel? Would you continue aspirin and add an oral anticoagulant, either a vitamin K antagonist or a direct oral anticoagulant, DOAC or NOAC? Or would you stop the aspirin and in its place start an oral anticoagulant? Those who did vote, thank you very much. Far and away, the most common sort of responses it was almost neck and neck were C and D. So options to either continue aspirin and add on an oral anticoagulant, or about half of you voted to stop the aspirin and start an oral anticoagulant. So let's just talk about the role of aspirin, particularly in stroke prevention for patients who have atrial fibrillation. This is drawn from the Averroes trial that took about 4,000 to 5,000 patients who either weren't presumably in the past tolerant of or thought to not be able to tolerate oral anticoagulation with vitamin K antagonism. And they randomized those individuals to receive a NOAC, a DOAC, in this case, apixaban. Compared in a randomized fashion to aspirin for a primary outcome of stroke or systemic embolism prevention. And I can tell you that the overall trial results were quite favorable for apixaban, an oral anticoagulant, in preference to aspirin for stroke or systemic embolism prevention. And the point of this slide is, as you can see, there was a particularly striking difference with a marked benefit of apixaban for stroke and systemic embolism prevention with older individuals compared to aspirin. So particularly in older individuals, but across a broad spectrum of atrial fibrillation patients, aspirin antiplatelet therapy, unfortunately, is quite inferior to oral anticoagulation therapy, in this case, apixaban, in preventing the dreaded complication of atrial fibrillation, stroke, or systemic embolism. And the perhaps surprising other finding was that there was no difference in major bleeding in either younger, on the left-hand panel, or older individuals. So the thought, at least in the past, that we should, preferentially give aspirin instead of an oral anticoagulant because we'll also experience, or the patients will experience, less bleeding, is not founded by these observations. And so really it's quite clear that in atrial fibrillation patients, not only is oral anticoagulation more effective than aspirin in stroke prevention, but it doesn't lead to any increase in bleeding relative to aspirin. So in this case, apixaban was just as safe as aspirin in atrial fibrillation patients. And because our patient, of course, has some chronic kidney disease, this is an analysis from Averroes that breaks patients' events down. Stroke and systemic embolism is the top series of rows, followed by major bleeding, and then all-cause mortality. And I think what you can appreciate is, regardless of the degree of renal dysfunction based on eGFR greater than or equal to 60 milliliters per minute versus less than, at least down to a level of 30, we can see that the benefit of apixaban over aspirin is maintained for stroke and systemic embolism prevention, and there are similar rates of bleeding comparing apixaban to aspirin, and numerically lower all-cause mortality risk comparing apixaban to aspirin. And so that, of course, is one of the reasons that the 2016 ESC, European Society of Cardiology, guidelines for antithrombotic therapy for patients with atrial fibrillation and stable coronary disease, like our patient case, suggest that oral anticoagulation monotherapy without any combination with antiplatelets is actually recommended for atrial fibrillation patients who have stable coronary disease, of course, excluding those those who've had a recent acute coronary syndrome or coronary intervention in the previous 12 months. So our patients, indeed, really we should be thinking ideally about stopping aspirin in this case and not adding any additional antiplatelet therapy, and instead for stroke prevention and for secondary prevention of stable coronary disease, replacing aspirin in this case with monotherapy with an oral anticoagulant. And of course, a NOAC, a DOAC would be a great choice. Follow up as we continue in our patient's scenario. So a couple of years later, the patient is again rushed to the emergency department, this time not having tripped or with any hip fracture, but because of an acute ST segment elevation myocardial infarction. You'll remember when I presented the original case, she had a prior history of a non-ST elevation myocardial infarction and had underlying coronary artery disease. The last time she had taken her NOAC was about 16 hours before she presented. And so indeed, in this emergency situation, really, regardless of when the intake of the NOAC was, the interventional cardiologist would take her urgently to the cath lab. And undertake primary percutaneous coronary intervention, stenting for management of the ST segment elevation MI. So she was stabilized and planned for discharge about 6 days after the procedure and after her initial presentation. And in the right hand panel, hopefully you can see the options as to the antithrombotic combinations and permutations that you might recommend in this individual. So she's already on apixaban, she's already on an oral anticoagulant, but she's had a stent placed, she's had an acute coronary syndrome, so the options are to continue apixaban, aspirin, and clopidogrel, which would have been given, at least the aspirin clopidogrel, acutely for the PCI and the ACS. Number 2, continue apixaban and clopidogrel, and at the time of discharge, after about 6 days worth of dual antiplatelet therapy, stop the aspirin. Option number 3 would be to switch away from apixaban and use vitamin K antagonism with warfarin instead, added to dual antiplatelet therapy. And the 4th option would be continue aspirin and clopidogrel, the dual antiplatelet therapy, but stop apixaban. So the most frequent was option number 2 or B here, which was to continue apixaban and clopidogrel and stop the aspirin. That was followed closely by continuing so-called triple therapy, all 3 therapies, option 1, option A, with a much less frequent choice to option number 4, D, to continue aspirin and clopidogrel and stop apixaban. So we've got lots of different choices here. What do the randomized clinical trial evidence support? Well, I had the pleasure of helping to design and carry out the Augustus trial, where we looked at these types of situations. So patients with atrial fibrillation who had an indication for lifelong oral anticoagulation for stroke and systemic embolism prevention, who were either presenting with an acute coronary syndrome and were managed medically, or who underwent percutaneous coronary intervention, stenting, like the patient case scenario that we've provided, or patients who had stable coronary disease and underwent elective percutaneous coronary intervention. And the Augustus trial did a 2x2 factorial, the only trial to do this, which made a comparison not only between vitamin K antagonism and apixaban in this setting, but also in a randomized fashion compared aspirin to aspirin placebo. And it's important to note that, of course, on a backdrop of P2Y12 receptor inhibitor therapy, mainly clopidogrel, although the choice was left to the discretion of the treating physicians. So all of these patients are receiving something like clopidogrel, and you can see that of the 4 arms that are listed here for the primary outcome, which was ISTH, or clinically relevant non-major bleeding, we can see that the arm as a patient that you did not want to be in, randomized to, was the top arm there in the solid red line, and indeed that shows the highest bleeding event rate over the course of time. Vitamin K antagonism together with warfarin, and this, of course, was followed. I'll use a little pointer here. So that's the worst arm here. This was followed in terms of the risk of bleeding by apixaban plus aspirin, and then the third lowest bleeding rate was vitamin K antagonism and dropping aspirin. But the best arm, of course, was this arm, the dotted blue line on the bottom. And so patients who were on clopidogrel, who maintained apixaban, but had their aspirin essentially effectively stopped by receiving an aspirin placebo, they far and away had the lowest major or clinically relevant non-major bleeding event rate. Now, we weren't powered, even though we had 4,600 patients, we were powered to look at major bleeding, clinically relevant non-major bleeding, but we were not powered to specifically look at ischemic events, but we pre-specified as a key secondary outcome in the trial the time to first death or any type of hospitalization, whether it was bleeding related, cardiovascular related, just any type of hospitalization and all-cause mortality. And you can see that, again, the arm that did the best down there at the bottom was indeed the patients who were on apixaban and aspirin placebo on a backdrop of mainly clopidogrel therapy. The blue dotted line had the lowest death or hospitalization event rate. And so clearly this was a very favorable strategy compared to the other three strategies. Now, going back to a patient population in Aristotle, where patients weren't recently undergoing PCI and or having an acute coronary syndrome, but just in general looking at renal function as a function, as a subgroup across the spectrum of atrial fibrillation patients, comparing apixaban to vitamin K antagonism, we can see consistently that bleeding, death or hospitalization or death or ischemic events was either statistically significantly lower with apixaban or at least favorable numerically from a risk perspective compared to vitamin K antagonism. So even amongst renal dysfunction patients, chronic kidney disease, we see consistent benefits of apixaban. And this is another way of looking at this important subgroup of individuals. On the far left here, we have those with relatively preserved renal function based on the Cockcroft-Gault estimation of creatinine clearance. Greater than 80. In the middle panel, we've got a sort of intermediate, greater than 50 up to 80. And then in the far right, we have those whose creatinine clearance is estimated below 50 milliliters per minute. And again, you can see very consistently that the group that does the worst, that solid blue line at the top, are those who were receiving vitamin K antagonism and aspirin. And this is now within, sorry, I said Aristotle, this is within our Augustus trial. You can see that the group that did the best in terms of bleeding was the sort of olive green line here at the bottom in each of the panels. So regardless of renal function, we can see that the group that has received apixaban on a backdrop of clopidogrel but dropping aspirin, the aspirin placebo group, those individuals experienced the lowest bleeding event rate over the course of time. And when we looked at our key secondary outcome, time to death or hospitalization by 6 months' time, which was the total duration of the study, again, you can see regardless of renal function in the three panels, at the bottom there, the olive green line, apixaban plus aspirin placebo and clopidogrel was indeed associated with the lowest death or hospitalization. And this was mainly driven by a reduction in hospitalization with the apixaban-based strategies. So we're always trying to strive to hit that sort of antithrombotic sweet point, particularly in people that have a recent acute coronary syndrome and or have undergone percutaneous coronary intervention and have atrial fibrillation and in particular may have some degree of chronic kidney disease. It's a balance where we want to prevent, of course, ischemic events, but we don't want to overload the patient with antithrombotic therapy to reduce that risk of ischemic events. concomitantly increasing the risk of bleeding events. So it's very important that we individualize. There's certainly no one size fits all, but in general, it looks like in this patient population that we can use something like apixaban very safely and effectively to prevent stroke and systemic embolism, that we can minimize the duration of the use of dual antiplatelet therapy and try to drop the aspirin, the antiplatelet, for one of the antiplatelet therapies, and just go with something like clopidogrel as soon as potentially possible.
All right, good afternoon. Thank you again for staying this far. And I hope you're all excited to join our first ECG challenge quiz for this afternoon and for the whole course. Okay, so will I be sharing screen or? All right, I hope you can see my slide. So I'll be giving the first ECG quiz. So take a look at this ECG. Okay, and this is our first question. Okay, given that the number of small squares between QRS complexes is 17, what is the ventricular heart rate of this patient? Okay, and here are your choices. A, 77, B, 88, C, 99, D, 110. Okay, so the poll is up. Please vote. Key in your answers. All right, so I'll show you the ECG again. Okay. So we have the poll results, and I'll discuss with you briefly, okay, the correct answer. So the answer that most of you answered, okay, 76% of you answered was letter B. Okay, so a heart rate of 88 beats per minute, and that is the correct answer. Okay, so I'll try and show the ECG again. Okay, hang on. Okay, so here again, okay, was the ECG we just looked at. Okay, so the stem of the question already gave you how many small squares are in between your two R waves. Okay, and that was 17. Okay, so remember the formula that we used to calculate heart rate in a regular rhythm. Okay, so 1,500 divided by the number of small squares, okay, between your R and R. Okay, and if you divide 1,500, okay, by 17, then the answer is 88. Okay, and this is a normal ECG. Okay, so I'll go to the next question. Okay, so again, soak up this ECG first, and I'll show you the question momentarily. So don't worry, these are very easy questions. Okay, so I'll give you the second question for the first ECG challenge quiz. Given that lead 1 is predominantly positive and lead ADF is predominantly positive, what is the frontal axis of the patient? Okay, so here are your choices. Letter A, between minus 90 degrees and 0 degrees. Letter B, between 0 degrees and positive 90 degrees. Letter C, between positive 90 degrees and positive 180 degrees. And letter D, okay, between positive 180 degrees and minus 90 degrees. Okay, so key in your votes now. So 8 seconds to go. All right. Again, okay, the majority of you answered, 69% of the group answered letter B, okay, between 0 degrees and positive 90 degrees. Okay, and that is the correct answer. Okay. Okay, so let's just go back to the ECG. Okay. All right, so all you need to do here, is go back to Dr. Magna's lecture about axis in a normal ECG. And if you go and use a very simple thumb method, then you should be able to get your answer right away. So look at leads 1 and ADF, and they're both positive. Okay, we didn't ask you for the exact frontal axis. Okay, we only asked you between what numbers, so ano yung range. And again, most of you got this correctly. Okay, so the axis here is about, anybody care to guess? Okay, so it's definitely between 0 and 90 degrees. Okay, but here we're looking at an axis of about 30, okay, positive 30 degrees. Okay, so for the last question for this first ECG quiz. Okay, so look at this ECG. So for the third question, question number 3, what is your rhythm diagnosis for this ECG? So very easy. I hope 100% get this correctly. Letter A, sinus rhythm. B, atrial fibrillation with controlled ventricular response. C, sinus bradycardia. D, junctional rhythm. So 5 more seconds to go for this poll. All right. Okay, so 56% of you answered letter A, sinus rhythm. Okay, about a quarter of you, no, 25% answered atrial fibrillation. Okay, while 14% of you answered sinus bradycardia and 5% answered the junctional rhythm. But the correct answer is letter A, no, sinus rhythm. Yeah, so for some reason, it won't go to the next slide when I'm pressing it. Okay, all right, so here, just again, take note that you have a very regular rhythm over here. If you count, okay, the number of small squares between your R's, it's relatively regular. There's a P wave before each and every QRS complex. Your QRS duration is within normal limits, so is your P wave duration. Okay. As for your QT interval, if you look very closely, it also falls within normal limits. Okay, so this is definitely not atrial fibrillation. Okay, and also not junctional rhythm because we have very clear P waves. Okay, I hope all of you were able to learn from the first 2 lectures so far, and we'll have another quiz after the following talk. Thank you.
Hi, good afternoon. I'm here to talk about the role of empagliflozin in the cardiorenal metabolic management in type 2 diabetic patients. Before I start, here's my disclosure. Micro and macrovascular complications is common in a patient with type 2 diabetes mellitus. You can see here that 50% of people with diabetes would probably die of cardiovascular causes. And end-stage kidney disease is 10 times prevalent more in patients with diabetes. And 60% of non-traumatic lower limb amputations occur in adult diabetic patients. And diabetes leads to 56% increased risk of hemorrhagic stroke. And those patients whose age is 40 years or more, most of them would probably have diabetic retinopathy. Therefore, a significant unmet need exists to reduce complications of diabetes mellitus. But before we diagnose our patients to having diabetes, cardiovascular disease can often occur, as seen in the schema that 10 to 15 years prior to diagnosis, that risk factors often appear and subclinical atherosclerotic disease often develops. That's why it's very important to address this early on. No? And once you diagnose your patients as having diabetes, you should screen them for pre-existing or existing cardiovascular disease. That is why for this afternoon, I'll be talking about this drug, empagliflozin, in managing these type 2 diabetic patients with established cardiovascular disease. And in this first slide of empagliflozin as an efficacy drug for lowering down your HbA1c, now in patients with baseline HbA1c of more than 8, comparing empagliflozin against sitagliptin, it showed that it has significant reduction of your HbA1c. And comparing the 2 doses of empagliflozin, whether 10 or 25 milligrams once a day,
did not show any significant difference. And with that, has established that empagliflozin could be part of treating your diabetic patients to reduce your HbA1c and get them to goal. And before that, we also would like to define their cardiovascular risk. And what do the current guidelines recommend? For the latest guideline for these types of patients, we must risk categorize them according to their duration of diabetes and their background risk factors. So it states here that they could be classified as moderate, high, or very high risk. But for this talk, we'll be focusing on the high and very high risk as defined here. Those patients whose at least the duration of diabetes is at least 10 years, and the diabetes is often with a background of established cardiovascular disease or patients with 3 or more major risk factors together with the diabetes. And with that, being of high or very high risk, we must do this risk factor control. Aside from doing glycemic control, we must advise them active lifestyle intervention, particularly weight loss. And also control their BP by giving them antihypertensive therapy, and controlling the LDL-C cholesterol to goal by giving statins, and for most of them, give an antiplatelet therapy. That is to provide a reduction of micro and macrovascular complications. And in this new guideline, it states here in the treatment algorithm that for those who are drug-naive diabetic patients at high or very high risk, you should start them on an SGLT2 inhibitor or a GLP-1R agonist as a monotherapy. But for those who are already on metformin, you should give them these 2 drugs again, the SGLT2 inhibitor or a GLP-1RA, and after that, you check their HbA1c to check if they have attained goal of less than 7. And they had also made these recommendations for the SGLT2, particularly these 3 drugs, empagliflozin, canagliflozin, or dapagliflozin, are recommended in this type 2 diabetes with high or very high risk to reduce CV events. But it was only empagliflozin that has been recommended for these high or very high risk diabetic patients to reduce the risk of death. Another recommendation for these 3 SGLT2 inhibitors, which are associated with a lower risk of hospitalization for heart failure in this high risk or very high risk population of diabetic patients, and are therefore recommended. With that, I would like to again reiterate to start these high or very high risk diabetic patients on this background treatment of statins or your RAS blockers, your beta blockers, and antiplatelet or anticoagulants as indicated to prevent progression of cardiovascular disease. As seen here in this continuum, wherein the end point would be heart failure and cardiovascular death. That's why is there the paradigm shift in terms of supporting this empagliflozin in treating these high or very high risk diabetic individuals? Because of the EMPA-REG trial, which showed a 38% relative risk reduction of cardiovascular death, which occurred as early as day 59 after giving or initiating this drug as compared to your placebo. And in this meta-analysis comparing these 3 SGLT2 inhibitors, that it was only the EMPA-REG outcome using empagliflozin that had attained significant reduction of cardiovascular death, particularly in these very high-risk patients with atherosclerotic cardiovascular disease. That is why in these studies leading back to 3-4 decades ago, that you should be giving these very high-risk patients this background treatment particularly your RAS blockers and statins, such as that with ramipril, simvastatin, and these newer drugs. No? But it was EMPA-REG, no? Which provided the earliest benefit for CV death, no? Wherein the number needed to treat is 39. You only need to treat 39 patients to decrease or to prevent one death. Therefore, with those evidences that I've shown to you, our local agencies, local government agencies, particularly the DOH and the FDA, have given the 2 thumbs up for its use to prevent cardiovascular death in these diabetic patients with established cardiovascular disease. Now we move on to the other aspect of the diabetic patient, which is heart failure, which is the most important preventable and treatable complication of type 2 diabetes, being at the end of the spectrum of the severe risk continuum. And in this study, comparing both diabetic and non-diabetic individuals, it has shown that congestive heart failure was 2.5 times more common in a diabetic patient compared to the non-diabetics, particularly those at the elderly age. And going back to the EMPA-REG outcome, that this particular outcome of hospitalization for heart failure, that it provided reduction of this outcome by 35%, and it happened as early as day 17 after initiating this drug of treatment. And empagliflozin on CV death was consistent in patients with and without heart failure burden. That's why for the EMPRISE study, which is the real-world evidence for this drug, namely the empagliflozin comparative effectiveness and safety, as a background, the severe risk continuum in type 2 diabetes, that approximately 1 in 3 patients with type 2 diabetes have cardiovascular disease. And with that, in our EMPA-REG outcome, the one that I have presented, that they have enrolled almost all patients with cardiovascular disease. But for this real-world evidence trial, they have also included patients without cardiovascular disease, comprising of around 75%. So what are the results? So this study compared empagliflozin and a DPP-4 inhibitor, and you would see that hospitalization for heart failure was significantly reduced with the use of empagliflozin. And another drug that is being compared to this drug is your GLP-1RA. And again, it has shown significant reduction of hospitalization for heart failure and a neutral effect on atherosclerotic cardiovascular event when given an empagliflozin or a GLP-1RA. And in a sub-study of this EMPRISE, you would see they have the subclass of Asian patients from Japan, Taiwan, and South Korea, that for the outcome of hospitalization for heart failure, it has retained that significant reduction for this outcome. And not only that, all-cause mortality as well as ESRD was likewise significantly reduced. And for heart failure, we have treatment goals. That is to relieve symptoms, improve quality of life, increase functional capacity, and more important is to prevent them from getting hospitalized and improve survival. However, drug therapies that are considered mainstay for treatment are only based for HFrEF, meaning only the HFrEF population had gained benefit. And reductions in mortality and hospitalizations reflect ability of therapies to slow or prevent worsening of this heart failure. And as I mentioned, HFrEF, these are the subpopulation of heart failure patients that has shown benefit in these numerous interventional drugs as well as device drugs and exercise. But for HFpEF, which is actually the more common heart failure subclass, still we have no specific therapy that is available to address these patients. And with that, it will be tested for empagliflozin. And I will showing to you this EMPOWER's group of studies for empagliflozin, which is still the largest cardiorenal metabolic program for an SGLT2 inhibitor to date, involving more than 27,000 patients. And I have shown to you the results of the EMPRISE and EMPAREG, but there are still other outcome studies that are still to be released. But for this afternoon, I'll be focusing to you on the Emperor Reduced study, which came out just last month, which stands for the cardiovascular and renal outcomes with empagliflozin in heart failure. So the aim of the study is to investigate the safety and efficacy of empagliflozin versus placebo on top of guideline-directed medical therapy in patients with heart failure with reduced ejection fraction, that is EF of less than 40%. And it enrolled not only diabetic, but as well as non-diabetic patients who are adults between NIHA class 2 to 4 with these confirmatory endpoints. And these are the inclusion and exclusion criteria. And to focus on the inclusion criteria, Japan had a higher cutoff of age at screening, but in terms of the EF being less than 40%, it was also paired with the NT-proBNP to be included in this study. So you would see that those between or the highest tier of the EF in HFrEF, they need to be at least 1,000 or more for the between 31 to 40, but those below 30%, at least 600 NT-proBNP would qualify for these patients. And if they are also not on background therapy, if they are on background therapy but are unstable, they are excluded. But comparing this to the DAPA-HF, you would see that the Emperor Reduced study enrolled a higher NT-proBNP cutoff for these patients. And atrial fibrillations were excluded or not included in the DAPA-HF trial. So what are the results? But before that, these are the hierarchical testing that will be checked or confirmed for the Emperor Reduced study. For the primary endpoint for adjudicated CV death or hospitalization for heart failure, it has shown a 25% relative risk reduction with a number needed to treat of 19. The secondary endpoint of hospitalization for heart failure, whether first and recurrent, provided a 30% relative risk reduction. And the secondary endpoint, which is a composite of renal endpoint, was reduced by 50%. And in these line graphs, you would see that empagliflozin significantly slowed the decline in kidney function against placebo in a 3-year period. That's why with this hierarchical testing of endpoints, Emperor Reduced was able to confirm these primary and secondary endpoints in this study. And also in Emperor Reduced, the safety profile was similar to the known safety profile as seen in the EMPAREG study, wherein there is no difference between groups in the rate of hypotension, hypovolemia, and hypoglycemia, and there are no cases of ketoacidosis. And you could combine it with linagliptin, which is a DPP-4 inhibitor, who is effective across a broad range of settings independent of age, disease duration, background of diabetes treatment, liver or kidney function, ethnicity, and body mass index. And to provide a holistic treatment for these diabetic patients, you can give this to and providing more sustained HbA1c reduction if you give this fixed dual combination of your empagliflozin and linagliptin, as compared to your monotherapy of either an EMPA or LINA alone. It was sustained reduction all throughout the 1-year follow-up. And as a key takeaway point, I've shown to you that diabetes is a leading cause of CV and kidney disease, and it's a leading cause of death, particularly of cardiovascular cause. In the 3 guidelines, I've shown to you that they recommended a cardioprotective glucose-lowering agent for all type 2 diabetic patients with cardiovascular disease. And in the 2019 guideline, you should be classified according to CV risk in terms of being high or very high risk. And it was only empagliflozin that was able to show a significant reduction in CV death, and it was the only one recommended in the ESC 2019 guideline. And together with other SGLT2 inhibitors, namely your DAPA and canagliflozin, they have the potential to lower the risk of hospitalization for heart failure. And to date, empagliflozin is the only oral anti-glycemic agent indicated for type 2 diabetic patients who have a very high risk background to reduce CV death. And emerging data from the Emperor study strengthened the CV benefits as well as safety of empagliflozin, and safety, efficacy, and simplicity of linagliptin across a broad range of type 2 diabetic patients can be combined with these two. You would see a powerful HbA1c reduction with the novel combination of your empagliflozin and linagliptin Glixambi, especially in a high baseline risk patient. With that, thank you for your kind attention.
Protecting the heart and the kidney will prevent the early, frequent, and fatal complications of type 2 diabetes. Forxiga is now approved in the Philippines for the prevention of heart failure or cardiovascular death in type 2 diabetes patients with and without cardiovascular disease. Do not delay. Protect the heart. Protect the kidney. Today.
Okay, welcome to the second ECG quiz for today. Okay, I'll share my slide. Okay, this is quiz number 2. Okay, so what you see here is an ECG. Take a look at your ECG first before we go to the question. Okay, so actually this is a very good example of the answer. Okay, so our question is, what is your rhythm diagnosis? So just the rhythm. You don't have to calculate for axis. You don't have to do anything like that. So what is your rhythm diagnosis? A, is it sinus rhythm? B, is it atrial fibrillation? C, is it multifocal atrial tachycardia? Or D, supraventricular tachycardia? Few more seconds. Okay, let's see the answers. Okay, so I was expecting actually 100%, but so a lot of you answered B, atrial fibrillation, uh, 768, that's 63%. Okay, and that is the correct answer. What we have here is an ECG from very irregular rhythm, irregularly irregular. And if you look at V1, you can see the very coarse undulations there. That is the undulations of atrial fibrillation. Okay, so there's no definite P wave. There's only fibrillatory waves. Okay? So it's most evident in if you're looking for fibrillatory waves, look at 2,3-AVF and V1 because that's where the quote unquote P waves are those are the ECG leads where the P waves are best seen. So even the fib waves. Actually, when you have coarse atrial fibrillation, you'll see it in V1 most of the time. This is our next ECG. So I'll flash the question. So the question is, what conduction abnormality is present? Let's go back. What conduction abnormality? So something about the conduction, not the heart rhythm, but the electrical conduction of the heart. There's something there that's not normal. Okay. So just take a look at the ECG again. So what conduction abnormality is present? A, left bundle branch block. B, right bundle branch block. C, second degree AV block. Or D, third degree AV block. Few more seconds. Okay, let's see the answers. Okay, majority, although less than half of you, so 49%, answered left bundle branch block. Okay, let's go back to the ECG. And you can see it's also an irregular rhythm, but if you look at V1 to V3 closely, and you look at before the QRS, there's still a P wave, and each P wave is still followed by a QRS. Okay, so definitely not a third degree AV block. And if you look at all the P waves, it looks like that they're all followed by a QRS. So again, not second degree AV block. Okay, so there's no non-conducted P wave in this ECG. So there's no second degree atrioventricular block. There's no third degree atrioventricular block. Now, the only two choices is left bundle branch block or right bundle branch block. Look at V1, it's predominantly negative, and the last wave is an S wave or a negative wave. And you can look at V6. Okay, so V6 is again, there's no Q wave. Okay, and if you look at the QRS, they're all wide. Okay, so this is left bundle branch block. This is the last ECG for today, for the ECG quiz. Let me take a good look. I'll show you the question. Okay, So we're looking for the rhythm abnormality seen in this tracing. Okay. What is the rhythm abnormality? So it's very obvious. There's a pattern, but it's not very regular. Okay? I mean the rhythm is not very regular. It's regularly irregular. Okay? It's irregular, but there's a pattern to it. Okay? So let's go back to the question. Okay? Rhythm abnormality seen in this tracing. A, is it intermittent right bundle branch block? B, are we seeing premature atrial complexes? C, are we seeing premature ventricular complexes? Or D, are we seeing an intermittent Wolff-Parkinson-White ECG pattern? Okay, can we have the poll? Okay, you can start answering the poll now. Okay, can we see the answers? Okay, a lot of you, 72% answered premature ventricular complexes, which is the correct answer. Let's go back to the ECG, and you can see there are sinus beats. Okay? There are sinus beats. There's a P wave, that's normal looking P wave followed by a narrow QRS. Then what follows is uh, a wide complex beat that's bizarre looking. As a preview to my lecture in the last day, you can see from V1 to V6, they're all upright. They're all R waves. Okay? So that's concordance, and they're very bizarre. And when you look at the before that, there are no P waves preceding them. So these are premature ventricular contractions or premature ventricular complexes. That's it for our ECG quiz.